Welcome to the first online live pharmacy medication instructional program hosted by Mandel's Clinical Pharmacy. Before we get started, I'm going to read this disclaimer you see on the page. This PharmAssist virtual learning experience brought to you by Mandel's Clinical Pharmacy is intended only as an educational program for patients. Any clinic-specific information shared by the nurses is the opinion of the nurse and is not intended to replace the recommendations or requests of your healthcare professionals. All medications will be dispensed by Mandel's Clinical Pharmacy according to the prescription as written by the provider. Thanks again, everyone, and again, welcome to the PharmAssist Virtual Learning Experience, an educational program created by Mandel's Clinical Pharmacy to bring you together with outstanding healthcare professionals right from the comfort of your home. PharmAssist takes place every Monday at 7 p.m. Eastern Standard Time. Tonight, we'll be providing a live medication instructional program on 3 fertility products, which are going to be Menopause, HCG trigger, and progesterone and oil, including interactive question and answers throughout the program. Please join us via Zoom or Facebook Live, and we invite you to be part of the discussion by sharing your questions in either format. We are joined by various amazing healthcare professionals each week from across the nation to provide you with real-world experience, just as if you were sitting across from them at the table at your clinic. Today, we are joined by Kaitlyn Endicott, and thank you again for your time and interest this evening, and then I want to turn it over to Kaitlyn.
Thank you so much, Morgan. Hi, everyone. Welcome to our live session tonight. As Morgan mentioned, my name is Kaitlyn. I'm a nurse practitioner in the Northern Virginia area. Tonight, we'll be discussing 3 different products. We'll start with Menopause, then move to the HCG, and then end out the night with progesterone and oil. After each video, we'll have time for questions and we'll do our best to answer them. But please do keep in mind that we can answer general questions about the products and medications, but we're unable to answer anything that is specific, to your medical history or why you're on a certain dose of any given medication. Those types of questions we will have to defer back to your clinic as they would be best to guide you with those. I think that's it for me. As you come up with questions, you can roll them in anytime. It doesn't have to be, in order with the video. So if you think of something that we talked about earlier when we're on the last product, that's perfectly fine. Please send them in. And I think with that, we are ready to get started with Menopause whenever you are, Morgan. In this video, I'm going to go over how to do a Menopause injection. First and foremost, I always say to collect all the supplies you're going to need. That way everything is laid out in front of you and it's ready to grab and go. So for a Menopause injection, depending on your dose, will depend on how many of the powder vials you're going to need. So when you get your Menopause in the box, you're going to have little vials that have powder in them. Each powder vial is 75 units of medication. So I have patients on as low as 75 or maybe half of that, all the way up to 300 units. So depending on what your dose is going to be how many vials you gather. So for today, I am going to do 2 powder vials. That way I can show you how to mix multiple vials. This would be the equivalent of 150 units. So I have 2 of those, and then 1 vial of saline. No matter how many vials of Menopause that you are prescribed on, you only ever need 1 vial of saline. You're never going to have multiple vials of saline. So most patients, if you're on more than 1 powder vial for your dose, you're actually going to have a bunch of saline left over. That's completely normal. Then you want to gather your 3 ml syringe, and this just comes out of the little container like this. You also want to grab an alcohol pad to cleanse the skin. You will also need a Q cap. It looks like this. It'll come in a box with, I think, 5 or 6 of them, so you'll need one of these. And then finally, you'll need a needle for injection. Here I have a 27 gauge 1/2 inch needle, but you can also do like a 1/2 inch 30 gauge, that's fine too. So after that, I usually line up all my vials and take all the caps off. So these just come off like that. So take all the caps off of the powder and your saline. Then you want to peel back on your Q cap. There's a paper here. This peels back and comes off completely. Now your Q cap is actually in the plastic, and you want to leave it in there. This part is sharp, so you don't want to prick your finger on there. Then you're going to grab your saline vial, and this will actually press into the rubber of the stopper into your saline. Then you can take off the plastic piece, and that's just trash. And now your Q cap is on to your saline vial. Then you want to take your 3 ml syringe. I usually recommend pulling back the amount of air that you actually want to end up pulling water out of the vial. So for Menopure, you only really ever need 1 ml of the saline to mix your vials. So pull back until you can see there my stoppers at the 1. Then you're going to take your saline with your Q cap, and this syringe is just going to twist on, so it'll be attached. Then you're going to flip it over, push your plunger up so that the air goes into the vial. Then when you let go, it's going to kind of naturally pull water back. When that happens, sometimes you can get a little bit of air in the top, and I'm not sure if you can see it there. If that happens, just push everything back up and then restart and pull back until your plunger is at the 1 and you have 1 ml of saline in your syringe. At this point, we want to get this water into our powder vials. So we need to take our Q cap with us. What I mean by that is you're going to take one hand on your saline vial, the other on the Q cap, and it actually just snaps like this so that your Q cap is still attached to your syringe. Then you are going to place it onto one of your powder vials. It goes through the rubber stopper again. Push the saline in. When you push the saline in, you'll actually see the powder dissolve almost instantly. Some patients like to kind of give it a little bit of a swirl around for good measure. Totally fine. Once you have pushed that saline in, then you're going to want to flip over again and pull back everything out of that vial. Now it's going to be roughly 1 ml because that's what we put in. Sometimes some of the water kind of dissipates when it mixes with the powder, so it might be a little bit less than 1 ml. That's totally fine. Once you pull back all of your saline or your mixed medication out of the vial, this is 75 units. 1 powder vial, 75 units in the syringe. If your dose is 75 units, you're done at this point. You don't need to mix any more, and you'll be ready to put your needle on, so stay tuned for that. But I am going to show how to mix additional Menopure vials just in case your dose is more than 75. So like I said earlier, for this video, I'm going to pretend that my dose is 150 units. So I am going to do the same thing I did before. We need to take our Q cap with us. So take off the empty powder vial, keep your Q cap onto the syringe. You're going to grab your next powder vial that you haven't mixed yet. Same thing. Push your cap on, push your saline in. That powder is going to dissolve. Then you're going to flip over, pull everything back. It's okay if you have some air in it at this point because we're going to prime our needle anyway, so we'll get all of that out of there. Once you have mixed this vial, we do not need our Q cap anymore. We have our dose. Our dose is 150. That's 2 powder vials. We are ready to put our needle on. Now, if your dose is higher than 150, then you're going to want to, at this time, move on to your next powder vial and keep mixing with this same 1 ml of saline. But for this video, we're going to go ahead and get ready to inject. So we do not need our Q cap anymore. Up to this point, we have held here and snapped off here. Now we don't need our Q cap. So we're actually going to twist this off, leaving our syringe by itself. Now, if you accidentally, just from habit moving along, and you take off your Q cap and it's still on your syringe, you can just twist it off and your syringe will be by itself. So now we have our full dose in here. We're ready to inject. So you're going to grab your 1/2-inch needle. This is going to peel like a banana peel. And here is your needle. And this just twists on to your syringe. At this point, I usually recommend priming the needle, which means kind of pushing up on that plunger until all of the air is out, until you see a couple bubbles come out of the top of the needle. Now, in this video, it might be hard to see through the lid that is on the needle, so I'm actually going to take it off to prime it just to show you. But when you're doing it yourself, you can actually see the needle through there. But you are going to push up until you see a few bubbles come out of the top there. Once you see a couple of the droplets come out, you know that you're primed and ready to go. So you can set that aside. Now you want to prep your site for injection. So this is where you're going to take your alcohol pad, pinch an inch of skin in the belly or in the thigh. This is a subcutaneous injection, so anywhere you can pinch an inch of fatty tissue, fair game. I usually recommend doing the belly for these. So you'll take your alcohol pad. This is going to be my skin for today. You'll open it, wipe off the skin, let it dry completely. That'll take away any stinging from the alcohol going in to the skin with the needle. Once it's dry, you can take off your cap, pinch your inch of skin, and you're going to go in fast at 90 degrees like a dart. So 1, 2, 3, and in. Once it's in the skin, you're going to press your plunger until it's completely in. Once it's in, you can take your needle out, get rid of this in your red sharps container, and at that point, you are finished with your injection. Now, depending on how many vials of Menopure you're ordered on, you might find as you're doing it after a couple days and you're mixing the saline that you're getting much less than 1 ml. A lot of my patients that are on 3 of the powder vials notice that they're all the way down to like 0.6 or 0.7 mLs. If that's the case, then you can actually pull back just a little bit more than 1 ml to mix. Like a 1.1 or 1.2, that can help keep the medication diluted throughout the water and less stinging with injection. Key here is to remember, you do not need to do multiple injections for multiple vials of powder, right? We kept mixing that same one over and over. It's like concentrating lemonade in a pitcher. You're not adding more water if you're concentrating it, you're adding more powder. So same amount of water, just more powder vials. I think that's all my tips and tricks for this one. I hope this is helpful, and that's how you will do your Menopure injection.
Awesome. Thanks so much. First question is, how long can patients typically expect to be on Menopure? How many days is like the average patient on that?
Yeah, great question. So I think typically the average is between 9 to 11 days, plus or minus a day or two. That would be what I would see is most common. But ultimately, it's just going to depend on how your body responds. So I would use that as an estimate, but that's why we bring you in for those frequent monitoring appointments. We're watching your blood work so closely and your ultrasound so closely to see how your body is responding. But typically, I would say between 9 to 11 days on average, probably the sweet spot. I've seen people though go quicker and people go much further. So, but that's why we watch you super, super closely. Great question.
Absolutely. And then when they're on these medications, is it pretty normal for the dosing to change, or is that something they should be worried about? Is that common? Can you kind of give some more feedback on that?
Yeah, absolutely. So, I would say it's pretty common for doses to change. So as we are watching your hormone levels and your ultrasound and your body's response, sometimes the body needs a little bit more. So maybe we increase the dose. Sometimes the body is responding super, super quick and we want to kind of slow things down a little bit. So we might back off the dose. Also, depending on what type of protocol you're on, you may be on an antagonist protocol, which means we are adding in a third medication partway through the cycle to keep you from ovulating. And that third medication can kind of naturally tap the brakes on the progression of follicular growth throughout the cycle. So sometimes when we add in that additional medication, we will increase your Menopure, or maybe you're on Gonal-F as well. We might try to kind of combat that tap of the brake by increasing up the dose a little bit. So it's not uncommon to start off on one dose, and by the end of your cycle, your doses are a little bit different, maybe a little bit more, maybe a little bit less.
No, absolutely. And I tell my patients not to compare their cycles to other people, because everybody is so different and they're definitely going to change, which isn't a bad thing. Or if your friend's is different than your dose is, that's completely natural. Every woman's body is so different. Another question is, what is the purpose of Menopure? What is it doing in a woman's natural cycle? Why would a patient be on this medication?
Yeah, so it's super important to know why we're on things too. Not only do we want to know how to inject them and make sure we're doing it properly, but it's nice to understand why we're doing it. So in a typical natural menstrual cycle, at the beginning of the cycle, all of our hormones are at baseline, nice and quiet, and we have all of these tiny little follicles in our ovaries that are waiting to respond and grow and develop a mature follicle for the month. This is done through the hormone released from our brain down to our ovary called FSH, stands for follicle stimulating hormone. It's doing just that. It is stimulating the growth of follicles within the ovary. Now, naturally, in most menstrual cycles, we're developing one follicle with one dominant egg in there to ovulate for the month. Now, what we're doing in IVF is we are kind of overriding that natural progression for just one follicle, and we want to stimulate the growth of many, many follicles so that we're getting as many eggs as we can when we get to egg retrieval. So the Menopure actually has this FSH hormone in it, and a little bit of LH, which is natural throughout our menstrual cycle. And that is talking to the ovaries and telling them to develop multiple follicles. So we want to stimulate as many as we can. So we're essentially mimicking a natural cycle with much higher levels of that FSH hormone so that we get many more eggs at the end of the cycle.
That was great. And then another question, it's kind of fun. I get this actually from a lot of my patient spouses, is patients have heard that Menopure can cause mood swings. Is that true? Can you give a feedback on that a little bit?
Yeah, absolutely. So, as the Menopure is working on the ovaries, and we get all these beautiful follicles that are responding, all of these amazing eggs that are producing then progesterone as they grow, estrogen as they grow, that hormone, as it increases and it's much, much higher than we're used to, can sometimes cause those kind of mood changes, mood swings, feeling a little irritable, even fatigued, nausea, basically PMS type symptoms on a much higher level, because we are causing that level to get much, much higher than it does in a typical menstrual cycle. So in association with that, those side effects that we experience during our time of PMS, those are also amplified. So it is very normal to feel those types of things and experience those. They will subside after egg retrieval. So you'll actually almost get this hormonal kind of plummet after the procedure, because we've now taken all of those eggs for ourselves. That producer of estrogen is gone. So everything comes back down to baseline really quickly. So it is normal to also feel kind of tired and fatigued after that. Those high shifts and jumps and plummets of hormonal changes can cause those types of things. So that is very normal.
Great. Thanks so much. Okay. I think that's all the questions I have so far on Menopure. Anything else you want to add before I go into the second video, HCG?
Just one thing, just to build off of what you had said, Morgan, of not comparing, your doses and your cycle to others. if you have to end up doing more than one IVF cycle, your own IVF cycles can be different from cycle to cycle. So it can be easy to want to compare your doses from cycle to cycle and want to repeat the exact same things. But sometimes we do see a vast kind of variability from cycle to cycle. So even if you do a certain dose for one cycle, it may be different in future cycles if you ever have to do more than one. So keep that in mind as well.
Gosh, so yeah, that's very, very true. That just shows how different every person is, and like your own cycles are so different. So you can't.
Oh, yeah.
That's such a good point. Okay, I'm gonna get the second video rolling.
Now I'm going to show you how to prepare and inject an HCG trigger shot. So first, I recommend gathering all of your supplies. You will need an alcohol prep pad, your medication. It should come in powder form. You can see a little bit of the powder there. Your bottle of diluent, so saline or sterile water. And then you will need your injection needle. So this will be a 3 ml syringe with a 1.5 inch needle attached to it. So to start, I recommend taking off all of your caps. So there will be a cap on your powder that'll just snap off, and same thing with your diluent. Next, you can open up your syringe. So it'll peel open like a banana peel. This comes out. Then I would go ahead and draw back the amount of air that you're planning to pull up of diluent. So this can vary from practice to practice. At my practice that I work at, we recommend mixing with 1.5 mLs of the diluent. So I'm going to pull mine back to 1.5. Take off your cap. Then you're going to insert your needle into your vial, push all of the air in, flip it over, and you'll kind of feel the plunger naturally pull back on its own. Make sure that your needle, and I'll turn it here, is in the actual liquid and not pressed up like this. Otherwise, you're only going to draw back air. So make sure you pull it down some and pull back until you have roughly 1.5 or whatever your provider recommends. Now you can see there I have a little bit of air in the top of my syringe here. You can actually push everything back up and start over. It won't hurt anything. So I'm going to pull back here. I have roughly 1.5. So now I can take this out. Now I'm ready to reconstitute my powder. So you have your powder vial. You see the rubber stopper here. The needle just goes right into there. Push saline in. And then give it a good little swirl. Helps things dissolve, but typically the powder dissolves just about instantly. Then you can flip it over. Again, make sure you pull the needle down so it's within your liquid. You can pull everything back. Now you're going to have roughly the amount of fluid that you put in. Some of it does get displaced when it is dissolving the powder, and that's okay. The most important part here is to make sure you get all of the liquid out of that vial. Once you have that, you now have your dose. You can take the needle out of the syringe, and now you're ready to prepare the skin site. So this is an intramuscular injection. So different from the subcutaneous injections you've likely done up to this point in your cycle. I usually recommend doing the upper outer quadrant of the buttock. So it's almost like the hip area in order to do this injection. So at this time, you can take your prep pad, clean off the skin site, let it dry, and then you actually want to pull the skin kind of taut when you do this to be sure that the medication gets to the muscle. When you're ready to inject, you go in fast, 90 degrees like a dart, and then push your plunger in. Take it out here, and you're all done.
Awesome. Okay, first question I have is, what is the main difference between HCG trigger and Avidrel?
Yes, so there are many different brands of HCG. So I think the main difference between the Avidrel and the other brands is that Avidrel is a recombinant type, where I believe the other ones are urinary HCG, but ultimately they're doing the same job. So they're mimicking an LH surge that causes that trigger for ovulation. I wouldn't say that one is better than the other per se. There are some times though where one may be preferred over the other. The Avidrel Dose, Avidrel is a pre-filled, for those of you that don't know, is a pre-filled subcutaneous HCG injection. So it's a little bit different than this one. This one is intramuscular. There may be times where the intramuscular is preferred because the Avidrel is a lower dose than that. So the intramuscular types, the HCG can be up to 10,000 units per vial. So whereas the Avidrel is much less. So depending on your treatment type and your goal at the end of the cycle, whether it be egg retrieval or maybe it's an IUI or timed intercourse, that will change typically the provider's preference of which one they want you to be on. But typically I would say the dosing of it all is what decides that across the board.
Great. Yeah. And I said, just usually it's, provider preference, their cycle, what their levels are. So don't worry if you're taking, again, HCG over Avidrel, it all is in your providers, like what they want to do. Okay. Another question came in is, are there different needle sizes for IM or for intermuscular shots, depending on body size? So different size needles compared to your body size. Can you talk about that a little bit more?
Yeah, absolutely. So when determining which needles are used for what, there's two things we look at. The first one is the gauge, which is the kind of circumference of the needle. So for intramuscular, usually you're looking at like a 22 gauge or even a 25 if the medication is nice and thin. The higher that number gets, the smaller the opening of the needle actually is. The other measurement we're looking at is the length of the actual needle itself. So probably more so what you were looking for in terms of an answer. So 1.5 inch, I would say, is the pretty standard needle size for intramuscular injections. Now, if you don't have a lot of kind of that subcutaneous fatty tissue on top of the muscle, then you may be able to get away with 1 inch for intramuscular injections. Typically, I would say that's something that usually requires assessment just to make sure that you would be appropriate for that size needle, because we do want to make sure that the medication is reaching the muscle. That's where it's going to be absorbed appropriately the way we want it to. And if we're doing these injections, we want them to be picture perfect and get our goals. So I would say that 1.5 is your standard. I think that there are clinical exceptions for smaller ones that are 1 inch in length, but I would defer to your provider on that.
Absolutely. And I would say too, I don't think I've had patients who kind of do both. And I would say they typically don't feel a huge difference between the 1.5 to the 1 inch, but yeah, definitely something to talk with your provider about. Now talking about the trigger shot, how important is it for you to take it at the exact time that provider takes? Is there a window of seconds, minutes, hours? Talk to me a little bit more about that.
Yeah, great question. So probably up to this point in your cycle, if you are doing other injections, we give a general time of day that we want you to do it and keep it consistent. But typically we're not super, super strict on that timing. But when the trigger shot comes, that's the one where whatever time we give you, we're like, please, please, please do it right at this exact time. But like you said, what does that mean? If I'm a few minutes late, a few minutes early, did I ruin my cycle? The answer is no, you didn't. There is some wiggle room in terms of seconds and minutes. Once we start talking about hours, that's where I would maybe check in with your clinic before you start your cycle. None of us plan to forget to do an injection or mix up the timing or anything, but life happens and we're human and we make mistakes. So I would check in with them on that prior to starting, so that where their threshold is. Maybe they're okay with you being 30 minutes off, 45 minutes off. Once we get to an hour, would they then change your eventual procedure, whether it's a retrieval, an IUI, or whatever your end goal is of your cycle? So I would check in with them, see where their threshold is. When do they want you to contact them? If you missed it by a certain amount of time or whatever it may be. Either way, though, you definitely want to let them know what time you ended up doing the injection if it wasn't right on, because we do look at that super, super closely, especially if you're doing an egg retrieval. We do our very best to be, in the OR ready for that procedure right at the exact time that we planned it out. But, if things are pushed 5-10 minutes on our end, then it might be nice for us to know if your trigger shot was pushed either way, because that then widens that window. So I don't have an exact answer for you. I will say that some clinics time out their trigger shots. I see differences of an hour, 2 hours. So there's definitely wiggle room there, but we don't want to play with it. So I would check in with your clinic and just see. In the worst case scenario, if you forget, at what point do you maybe call, if they have an on-call line for an emergency help, what point do we utilize that? Or what point do we just go ahead and give it to ourselves?
No, it's great. I think there's always having open communication with your clinic or your nurse or doctor is so huge. Even if it is a couple minutes, I always say I rather know my patients call me and let me know. And more than likely, everything's absolutely fine. But just to be on the safe side, it's always good to be in the know just in case something happens. But I always say also set multiple alarms because it is very important.
Yes.
Set 3 alarms if needed. You can't do it enough, but just try to make sure you're trying to hit it on time. Okay, last question I have here is, what are possible side effects of the HCG trigger? Talk to me more about that.
Yes. So HCG trigger, there's a few different things to think about. Similar when we were talking about the Menopause and the mood changes and irritability and things like that because of the estrogen level being high from that medication. Some patients get a similar response from a trigger shot because, again, we're sending the LH type response through the roof. So we're ovulating, right? These hormonal shifts. We're giving ourselves a big dose of HCG to mimic that shift. Also, I do have some people feel kind of ovarian pain because we are, making ovulation happen. In some cases, that's the goal if you're doing an IUI or timed intercourse, or maybe we're trying to catch those eggs right before they ovulate if we're doing an egg retrieval. And so sometimes feeling little twinges and some sharp pains here and there can be normal from the trigger shot as well. I think that's something just overall with any of your injections that's important to think about, and it's not as prevalent anymore as OHSS. I'm sure that this is something that you've heard from your clinic about, but it's ovarian hyperstimulation syndrome. As we're giving these injections, the ovaries are responding with multiple follicles. They're growing in size, and all these hormones are high, and then eventually we give this trigger shot, which can cause essentially the vessels can get permeable and cause these fluid shifts. So they get leaky, can cause fluid to build up on other organ systems. Again, I would say this is rare nowadays. It used to be more prevalent, but we have treatments for these things, utilizing different trigger shots and so forth. But I would say that would be a more severe side effect of the cycle and mainly the HCG trigger, but we know now how to kind of combat that as we're tracking your estrogen level. We can use other medications to decrease this risk as well, but that's a big one that I tell my patients we have a low threshold for. If you're having any issues breathing, talking, noticing fluid building up on the belly, issues walking, not urinating easily or at all, that would be a reason to give your clinic a call after retrieval.
No, great. And I think you said I would say it's very rare. I would say in the past year, I maybe had 2 patients that had OHSS and it was just moderate. But definitely those are I would say the biggest side effects that we warn patients about. So that's great. I think that's all the questions I have right now. Is there anything else you want to talk about on HCG?
I don't think so. I think I'm ready to move on.
Perfect. So the next video is going to be progesterone oil, and I'm going to get it going now.
Now I'm going to show you how to do a progesterone and oil intramuscular injection. First, I recommend collecting all the supplies that you need to do the injection. So first and foremost, of course, you need your progesterone and oil medication. So collect that vial. Next, you will need a syringe and needle. Typically, it's a 3 ml syringe that's used. A lot of times they will come with needles attached onto them. For the sake of this video, my practice uses the 22 gauge needle to inject and an 18 gauge needle to mix. I recommend talking to your provider about what they prefer you do for your treatment. So here I have the 3 ml syringe with a 22 gauge 1.5 inch needle. So then I also have a 1 inch 18 gauge needle to mix. You will also need your alcohol prep pad. So at this point, go ahead and take the cap off of your progesterone and oil. It just snaps off here. You'll see the rubber stopper on top. Then open up your syringe that has the needle attached. It'll peel open like a banana peel. And then you can open up your needle that you'll use to mix. Now, if your provider wants you to use the same needle to mix and administer, you won't need to do this step. So that second needle opens up like a banana peel as well. I recommend avoiding touching the top of this cap here and keeping that sterile. Then if you twist, your other needle will come off. You can set that down to use later. Then this needle will twist on. If you twist to the right, then you can remove the cap. And again, at my practice, we typically have doses of 1 ml. So for the sake of the video, that's what I'm going to use, but I would confirm this with your healthcare provider. So I recommend drawing back to the number that you will use to administer. And what I mean by that is if I'm using 1 ml, I'm drawing back right now 1 ml of air. So you can see my plunger is right at that 1 ml mark. Then you will take your vial and the needle goes right into that rubber stopper. Then push your air in, flip the vial over, pull your needle down slightly to be sure it's in the liquid and pull back, and you'll see the medication pull back into your syringe. And it is oil, so it's a little thicker, so it might take a little bit of help of you pulling down on the syringe. Now, if you have some air, that's okay. You can push back up and start over. That's perfectly fine. So like I said, I'm using 1 ml for this video, so I have 1 ml of the oil here. Take this out. So now I'm ready to administer. I do not recommend administering an intramuscular injection with an 18 gauge needle, which is why I saved my 22 gauge needle here. So this will twist off, put it directly into your sharp spin. No need to recap it. And you'll twist on your needle to inject. So now we are ready. It's time to prep our injection site. For the sake of the video, this is going to be my skin and my muscle. When you're doing it at home, I would confirm with your healthcare provider if they have a preference of a site for intramuscular injections. I typically recommend using the upper outer quadrant of the buttocks, so it's almost like your hip area to do the injection. So once you have chosen your injection site, open your alcohol prep pad, clean the site with alcohol, let it dry completely. Take the cap off of your syringe, and then you're actually going to kind of pull the skin taut, and then you will inject quickly, fast like a dart at 90 degrees. Fast there, all the way to the hub, and then press the oil in. Now it is thick, so it can take a moment to go in. Typically in skin, it's a little quicker than my cube here. Once the injection is in, you take your needle out. There might be a little bit of oil that comes out of the site, and that's okay. You can just wipe it up with some sterile gauze, and then you can recap your needle, put it into your sharps container, You're done. Now, one thing I like to mention with the progesterone and oil, especially because a lot of times when patients are taking this, it's for extended periods of time, weeks on end. So the oil can actually kind of collect if you're not active and moving after you do the injection. So the worst thing you can do is go back to bed, wake up in the morning, do the injection, go back to bed and let it sit. I recommend massaging the area. You can take like a tennis ball or a lacrosse ball and kind of knead it on the area as well. Heat can help disperse the oil as well. Just if you use the heating pad, be very, very careful that you pay attention, only use it for small amounts of time. And then being active. So walking around, going for a walk, things like that can help to disperse the oil into the muscle as well.
Awesome. Thanks for that. And I think great tips. I always tell patients they take it in the morning to like get in the shower, like a hot shower afterwards. So really just help disperse it as well. The first question that came out is what are the different types of oil? Someone said that their friends are different types than they are. Can you kind of talk about that in a little more detail?
Yeah, absolutely. So depending on, basically, it's usually a pharmacy preference of what type of oil they want to mix the progesterone in. That's usually, I think, what decides it. Sometimes it's sesame, sometimes it's olive oil. There's also ethyl oleate, which is a different kind of compound to mix with. Usually, if you have an allergy to one of the other oils, then the ethyl oleate is going to be what is specifically prescribed for you. It can be just a tad more expensive than the basic oils, but other than that, they're doing the same thing. So it's still delivering the medication and doing its job. But I think typically, unless your provider has a strong preference, we usually defer to what the pharmacy prefers to mix with.
Awesome. And then talk to me a little about the different types of progesterone. So someone said they're on suppositories, there's pills, there's oil. Why would a patient be on one over the other? Or what are the different types of those?
Yeah. So like you said, progesterone comes in many different routes. Honestly, the progesterone and oil, we call it liquid gold. It really just is the best way to absorb the progesterone and get the most out of it all. So you have the intramuscular injections. There's also capsules that can be taken orally or even inserted vaginally, as well as suppositories that are inserted vaginally. So there are definitely different routes. It's going to depend on your treatment plan. So typically, if you undergo a fully medicated transfer cycle, meaning that your clinic is completely in the driver's seat with the hormones, and we are not counting on your body to develop a dominant follicle for the month. We are going to totally take over and provide the body everything it needs for implantation and pregnancy. Typically, that type of protocol is going to call for the progesterone and oil because it really is the gold standard. It's the best way to do it. And so we want to make sure that you are getting the most you can because your body is not actually producing it on its own. We're providing it. If you are doing a cycle that we are dependent on your body to develop a dominant follicle, so maybe that is an embryo transfer cycle, maybe that's an IUI or timed intercourse cycle that you're planning to do progesterone afterwards, that's perfectly fine. But what we do in those cycles is we actually trigger ovulation to occur so that the egg leaves the follicle, and then what is left behind, the follicle kind of shrivels up and it forms what we call a corpus luteum. And that structure actually produces progesterone to support early pregnancy. So in that case, if your body is producing its own progesterone, then maybe we just want to add in a little bit of light supplementation like a suppository. So depending on what type of cycle you're in, usually is what mimics and dictates which compound or route that you are on.
Perfect. You kind of touched base on this a little bit, but why is progesterone so important in these transfer cycles? And then usually how long can patients plan to be on them until their body starts making it by itself?
Yeah, great question. So progesterone is the hormone of pregnancy in terms of you have to have that hormone to have a successful pregnancy. And like I said, in natural cycles, that corpus luteum is hanging out and it's producing that progesterone. There's research that has different time frames in terms of when the placenta takes over. There's some that say as early as 6 weeks, some lean more towards the 8-week mark. Your clinic will probably have some sort of weaning protocol that it follows of when to stop the progesterone and start to back down on that. But usually the placenta is taking over between 6 to 8 weeks, I would say, is probably the majority of studies. Sometimes we will have you stay on it a little bit longer just for a little extra support. But really, you shouldn't need to be on it after the first trimester for certain, but usually you could be off by like 10 weeks. But we usually do a slow wean. But yes, you absolutely have to have that progesterone hormone in order to support a pregnancy, which is why this medication is so, so, so important.
No, totally. I love how you say it's like the liquid gold. It's our standard too. It's what we've been doing. I think it's the medication's been around the longest, if I'm not mistaken. So definitely super important. Now, a lot of people are scared of this medication. There are probably horror stories. They hear it hurts a lot. Any tips to help with the pain of giving the injection? And also, is it better for someone else, like a partner or friend, to give it, or is it okay to give it yourself?
Yeah, great question, a common question, and it's normal to have that question. So first and foremost, I would say that it's totally up to you if you want to do the injections yourself or if you would rather your partner do them. I have patients that do either one. I will say that I usually offer to draw circles of where the injection can be done so that we're making sure it's done in the right spot. And also it takes away one thing that you have to worry about, wondering, am I doing this in the right spot? Is this the right way to do it? If I'm sure if you ask your clinic, they'd be happy to outline the site for you. So that can be super helpful. And then also rotating sides every other day, one side one day, one side the other, that can help. I would say that the thought of the intramuscular injection, the length of the needle is scary. But I have most patients say that the actual injection itself isn't painful really at all, or they barely feel it. It's more so the oil, the couple hours after, that becomes a little more tender and sensitive. And so, like I mentioned in the video, anything that you can do to help that oil disperse and absorb will help to decrease that tenderness over time. We also do have a video on the main page. If after this you go to the individual med instruction videos on our website of Sanera patches, they're a numbing patch that you can put on 20 to 30 minutes before the injection. And that can just help to kind of take away that initial, feeling of the needle. And it can also take away that initial tenderness of the oil kind of sitting there. The patch also does heat up. It's part of the mechanism of how it works. So that heat that it provides, I've had some patients say that even helps in dispersing the oil just right from the get-go. So if you're interested, that video is posted, and that's definitely something that you can utilize as well.
So I think Sanera patches are awesome. I also think there's this huge stigma of fear around the injections. And I think once you get over your first one, you'll realize that, yes, it's not the best thing, but they're not as scary or uncomfortable as a lot of the fear probably leading up to that, which obviously we haven't ever given ourselves injection. So that's pretty fair to be scared. But they're usually have patients come tell me, they're like, it wasn't as bad as I thought it was going to be. So last question I have coming through is possible side effects of being on the progesterone. Just what's kind of like the main ones and what's something to look out for?
Yeah, absolutely. So I would say that the main kind of side effect is that tenderness in the area. You might kind of feel almost like a knot in the area, and that's that oil. So you really want to work that out and work around that. If you feel it somewhat collecting there, maybe move over, an inch or so around it for your injections. Don't keep going in that same spot over and over. Kind of give that time to recover. Also, I would say the most common side effect outside of those that I have patients tell me about is kind of a superficial irritation or almost like a rash that can form around the injection site. That is pretty normal. It's just irritation over time because these injections are usually, being administered for weeks at a time. So after a couple of weeks, sometimes that can surface. I'm typically fine with my patients using like an over-the-counter cream on there, like a hydrocortisone, just to help with that. Itching as well can happen at the injection site, but I would confirm, with your provider if they're okay with you using a little bit of over-the-counter hydrocortisone to help with that. Sometimes switching up the oil type as well can help with it. If it continues or becomes somewhat unbearable, that can help too.
Awesome. Those are great tips. Okay. I don't think I have any other questions. Any other feedback or things you want to talk about on progesterone oil before I close this out?
I think the only other thing with progesterone and oil, like I said, is if your clinic is open to drawing, the circles of where it needs to be administered, that's helpful. But if you're experiencing a lot of pain with these, usually it's because they're being done too low. So it's already an odd feeling, right? Giving ourselves injections. It's even an odder feeling doing it kind of higher up on the hip than you might think is normal. So if you're having a lot of pain, I would definitely have your nurse take a look and just make sure you're doing it in the right site. Because I've had some patients that do it kind of lower on the buttock, and that does cause more of the pain. The muscle kind of thins out as it goes down, and more fatty tissue gets thicker as you go down, so it can accumulate in that tissue, and that's not what we want. We do want it to get to the muscle. So have them take a look. When I've done that and we've had them move it up a little bit higher, it really does make quite a big difference. So keep that in the back of your mind as well. But I think that's it for my tips.
And also just making sure that they go in, because sometimes I feel like patients are scared to inject it all the way in because it's a longer needle, and sometimes if it's not in the muscle, it can cause that as well.
Yes, absolutely.
Okay, well, thank you so much, Kaitlyn, for all your expertise and answering all of our questions. And want to thank everyone else who joined via Facebook or Zoom. Your questions were awesome. We hope that you had your questions answered and this was helpful. I do want to remind everyone that we do have these videos from tonight and all the individual medication videos available on Mandel's Facebook page, the YouTube page, or at MyMandelsClinicalPharmacy.com/PharmAssist. And also just a reminder that we do these video live events every Monday at 7 p.m. Eastern Standard Time. We do 3 new medications each week. So if you didn't see your medications tonight, please join us next week as well. And then please share this information out to any friends, family members, anyone else that's going through treatment. And we hope to see you next week. Thanks again, everyone.